Greetings. This is the 6th video in this series on mood disorders. I think this is going to be the last video as well. This talk is going to be about disruptive mood dysregulation disorder, which is a bit of a mouthful. We'll call it DMDD. And DMDD is a new disorder to the DSM-5. And it's a little controversial. And it's kind of interesting. This is a disorder for children. It's diagnosed in children. And let's look at the diagnostic criteria that we have here, and then we'll talk a little bit about the pros and cons of this disorder. So the primary feature of DMDD is temper tantrums. Huge temper tantrums, verbal outrages, physical aggression, and they are grossly out of proportion in both intensity and duration. So they're really big and they're long, and they don't match the situation or the provocation. I will tell you that I have seen a child have an 8-hour tantrum. So that's really long and really severe and really exhausting for everybody involved. The temper outbursts are inconsistent with the developmental level. So if you have a 12-year-old or a 13-year-old who is having severe temper tantrums, that's inconsistent with their age. You'll see that the onset for DMDD shouldn't be before the age of 6. So we don't diagnose it in children under the age of 6. And the reason for that is the frontal lobe isn't sufficiently developed until 6 years old for a child to really have mood regulation. What that means is that when we say mood regulation, we mean the ability to manage their moods, to soothe themselves, to calm themselves down, and to have some control. So, in other words, maybe you've seen this. You see a 3-year-old, and the meltdown begins, and you can see it. You can almost like see the face crumble, and the quivering, and the emotion is beginning. And most parents know that there's a point of no return. And at the point of no return, the child cannot bring themselves back. Somebody is going to have to soothe that child or wait until they exhaust themselves. But we don't expect a child under the age of 6 to be able to calm themselves down. That doesn't mean that some can't. Quite a few can. But it's not an expectation. After the age of 6, we can developmentally expect it. That's what this is saying. So, not consistent with developmental level. The mood between temper outbursts is irritable or angry most of the day, nearly every day, and is observable by others. So other people notice this. It's not just reported by the child. All of these criteria have been present for at least 12 months. Remember, that's the duration now. 12 months for signs and symptoms. During that time, they haven't had a period lasting 3 or more months without all of the symptoms. So all of these symptoms are present, and for no more than 3 months, they might have some of the symptoms and not all, but no more than that. These symptoms are present in at least 2 of 3 settings. So we have homeschool and peers. And we want to see these symptoms in at least 2 of those for diagnosis. And the symptoms need to be severe in at least 1 of these. This starts getting a little tricky. We'll talk about that. Again, and here we see the age. Diagnosis should not be made before the age of 6 or after 18. So, this is a childhood disorder. So after 18, you would not diagnose anybody with DMDD. By history or observation, so either you've seen it or you heard, the onset is before 10 years of age. So in other words, this started between the ages of 6 and 10, but you wouldn't diagnose it after 18. So maybe a 14-year-old comes to you, and from taking a history, you realize that they've been having these symptoms since they were about 8 years old. Or yeah, they were still having that. Maybe they were having them when they were younger, but definitely after the age of 6 and before the age of 10. I hope that makes sense. And there's never been more than one day for which hypomania or mania have been met. And we'll talk about why that is. This is very interesting. So what you're seeing here is a child who is very, very frustrated and angry and irritable. There's a lot of crying and screaming and raging, getting into trouble, a lot of loss of control. And this is going on for a long time. And we're seeing it in 2 settings, either with school and friends, school and home, home and peers, school and peers. So now let's get a little bit of history about what's going on here. So the reason that the DSM-5 came up with this disorder primarily, was because you may have heard there was a significant rise in the medicating of children. So what was happening was children were getting diagnosed with bipolar disorder. Really young kids, a 5-year-old might be diagnosed with bipolar disorder. And now you know something about bipolar disorder. And then they would be treated with major antipsychotics, mood stabilizers, antidepressants, really big guns in terms of medication. And what psychiatrists and doctors were saying at the time was, well, even though their bipolar disorder doesn't look like what it would look like in an adult, it looks different in children. In children, it looks like a lot of tantrums, so we're just going to call that bipolar disorder and give them medication. And what DMDD does is say no to that. So here, let's look at the next slide, actually. So what DMDD does is it reduces the diagnosis of bipolar disorder in children. Because now that we have this disorder, you can't diagnose bipolar disorder in children unless they meet the exact same criteria that adults do. So if you see the same symptoms that are listed for bipolar disorder, that we saw full-blown major depressive episodes, full-blown manic episodes, and meeting all of the criteria, then you can diagnose it. It's just very, very rare in children. But what you can't do is diagnose what we just listed as bipolar disorder. Now it has its own category. And the recommendation for DMDD is not to medicate. Instead, the treatment recommendations are to look at what's going on in the family, what's going on at school, what's going on at home. What is going on? Why is this child having such a hard time? As opposed to saying, this child has a serious psychiatric disorder, it's probably biological, and let's medicate them. Instead, it's saying, let's look at the environment and see if there's something going on. Now, sometimes you can't detect a problem in the environment. Things seem to be okay. Nobody's perfect, but there doesn't seem to be a significant cause for symptoms. So then treatment might involve helping the child to regulate their emotions, teaching a child how to self-soothe and take care of themselves, take care of their emotional distress, which is very different from major antipsychotic medications, right? So there's a lot of benefits to this disorder for children. Now, there's some concerns. There are risks here. There's the risk of diagnosing a child's reaction to an unhealthy situation. Now, like I said, you're not supposed to do that. And, if the child is in an unhealthy situation and they're showing signs and symptoms of DMDD, we should be treating and not thinking about the diagnosis necessarily. But if the diagnosis helps, then that's okay. We risk pathologizing children when we give them diagnoses. And you might have a child who is just very spirited and can't regulate their emotions and is all over the place and flies into rages. That happens. And maybe you don't want to diagnose that child, but the key here, I think, is that we shouldn't see diagnosis as either an accusation or a judgment. What diagnosis should do, hopefully, is just lead us to treatment, and to treatment that would be appropriate for a child and appropriate for the child's situation. So that's disruptive mood dysregulation disorder. I hope that helps with understanding this.